Hello everyone and welcome to today's webinar, Navigating STI and AMR Trends, Implications for Public Health, Diagnostics, and Treatment. I am Cassie Saltman of LabRoots and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Applied Biocode. To learn more, visit apbiocode.com. We encourage you to participate today by submitting any questions you may have during the presentation. To do so, simply type them into the Ask a Question box and click Submit. We'll answer as many questions as we have time for at the end of the presentation. You may also use the Ask a Question box to let us know if you're having any trouble seeing or hearing the presentation. I'd like to now welcome our speakers for today's webinar. Dr. Mark Pandori, Chief of Sacramento County Public Health Laboratory, Dr. Bijaya Dekal, Director of Molecular Diagnostic Laboratory at Sonic Reference Laboratory, and Joe Davis, Senior Director of Operations and Pathology at the University Clinical Health. Dr. Pandori, you may now begin your portion of the presentation.
Thanks, Cassie. I appreciate the introduction. I'm excited today to talk about one of my favorite subjects, which is the molecular detection of sexually transmitted disease organisms. But we're not just going to talk about detection. We're also going to talk about the description of STD organisms through molecular means. Because molecular detection is based on the detection of DNA or RNA, molecular tests give us the opportunity to describe these organisms while we detect them. And that might mean looking for a certain strain or looking at drug resistance, as we're going to talk about for a few of these organisms as we get going here. In terms of an overview, we're going to cover the methods. So it's always a pretty broad audience when I give this talk. And so I like to ground the talk in methods and say, get us all on the same page with regard to mechanics. And well, it says I'm going to talk about culture and nucleic acid amplification testing. I'm really going to talk about culture only in comparison to these methods and relative to these methods and how it relates to these methods. When we talk about sexually transmitted disease organisms, we are talking in this lecture about chlamydia, gonorrhea, Mycoplasma genitalium, and Trichomonas vaginalis. And we'll go over what methods are available out there that you can actually buy from an FDA cleared perspective to get those detected and described perhaps. And then we're going to get into some very special descriptive considerations. As I said on the last slide, we're going to talk about the detection of drug resistance using molecular methods. So before we get into the methods themselves, why use nucleic acid amplification testing? We were doing culture for years and having really no issues detecting a lot of these organisms. Well, a lot of us already know why. Number one, molecular methods are easily automated. If that means we can have machines do them, that frees up our time and our hands to go do something else. And it takes away the opportunity for a manual error on the side of the microbiologist or diagnostician who's running the test. These machines are also very multiplexable. That means we can run multiple organism detections at the same time on these instruments. They're also, as we probably, some of us know at least, these are extremely sensitive methods. And to get things to culture might require hundreds or even thousands of living organisms. Here, molecular methods which use target amplification can detect in some cases less than an organism. And I know you're wondering, how can that be? And I'm going to explain that when we get on and talk about the mechanics of some of these, what we call NATs, or nucleic acid amplification tests. They don't require much experience because they're automatable, and because, or if they're not automatable, it really is just mixing a few chemicals into a tube and putting it into a machine. It means that you don't need much experience to do molecular tests for STDs. That's really good because that means we all know, to do bacteriology or virology, the old methods, you've got to spend years to develop that trade and that skill. And a lot of people of those people with those skills are retiring now. And people really, we need to test for those things. It's a lot easier to get people that have been working in the lab for just a few months or a year to be able to do them. And so, again, these methods are really easy and you can get someone up and running really within just a couple of days. And they're fast. It's not unusual for some of these tests to take, anywhere from 1 to 3 hours before you can get a result and get things in the machine. Once you get them in the machine, for these things to go about 1 to 3 hours. So you're not waiting days like you are for culture. So nucleic acid amplification tests, now that we know why they're beneficial to the world of diagnostic science, let's talk about where they come from. Well, on the right part of this slide is what we call in molecular biology the central dogma. DNA exists and it can replicate itself in the presence of certain enzymes. DNA can be copied. PCR takes advantage of that ability to replicate DNA strands. DNA can be transcribed into RNA in biology. We call that transcription. And TMA, or transcription-mediated amplification, which is another NAT test, takes advantage of that aspect of it. Strand displacement, which is another nucleic acid amplification test that exists in the FDA-cleared world, actually takes advantage of DNA repair. And that's something that isn't part of the central dogma, but is part of the central understanding of molecular biology. So you can see how the central dogma, the ability to copy DNA and the ability to transcribe DNA, has been, through a biotechnology lens, been seen now and now converted into technologies that allow us these sensitive detection methods. There are even waived molecular methods now for like CT and GC, and I'll touch on that briefly. PCR, so copying DNA, replicating DNA. That's what PCR does. The polymerase chain reaction is a way of taking a double-stranded DNA molecule, melting it, and in the presence of sequence-specific, or you might say species-specific primers, you're able to copy each of the strands of the DNA and then repeat that in cycles over and over again using a process called thermal cycling. You don't need a living organism to do PCR. You just need the organism's nucleic acid, which might still exist even in a dead organism. And in an hour, you can really turn just a few copies of target DNA into billions. So you can see the amplification concept here is you're amplifying more of your target. You're not doing what you might call signal amplification, which you would see in something like an ELISA, for example. Transcription-mediated amplification has more steps. Instead of melting the DNA into two parts and then hybridizing primers and extending those primers, what you're doing is you're taking RNA as a target. There's lots of RNA in biology and in organisms, and that also has sequence species specificity to it. Sorry, go back to that slide. So what you're doing in transcription-mediated amplification in the first step is converting an RNA target into a DNA target through the process of reverse transcription. And then after you've converted the RNA target into a DNA target by reverse transcription, you're then running transcripts off of that double-stranded DNA target. And so while PCR takes a DNA target and doubles it in each cycle, TMA takes a DNA target and runs transcripts off of it, which might be thousands of transcripts that are generated over the course of a minute. That's how fast transcription can occur. The other thing that's very powerful about TMA is that because you're using RNA as a target, you can target ribosomes in cells. There's generally around 10 to 50,000 ribosomes in microorganisms, and the ribosomes have sequence aspects to them that are specific to species. So that means that the ribosome sequence, some ribosome sequence, can tell you what species you're detecting. So that means that every organism that you could potentially be looking for might have something like 20,000 targets in it. And so remember when I told you earlier that you could detect less than an organism? Well, now you know. If one of these organisms died and broke open and spilled its ribosomes out, you could detect a couple of dozen of those ribosomes, and you'd be detecting like 1% of the ribosomes in that organism. So you can see how powerful it is. So not only is it taking advantage of the transcription aspect of the central dogma, it's also taking advantage of the fact that there's many targets. So with regard to our 4 STD organisms that we're talking about today, virtually all the companies that make tests for gonorrhea and chlamydia combine those into a dual test. There is a manufacturer that makes an FDA-cleared PCR that makes a 4-plex for all 4 of these STD organisms. So there's quite a lot of convenience. So on top of all the advantages there that we talked about, remember that I talked about multiplexing. And so there is, in fact, now an FDA-cleared PCR on the market that means it's a one-stop shop. And you'll get all those molecular advantages in a 4-plex. Most of the NATS test specimen collection methods involve the generation of a non-viable specimen. So that means that when you take a swab of a lesion or a sore, and then you put it in the collection vial to get it to the lab so the molecular test can be run, you're actually, in virtually every instance, killing the organism. The reason for that is that there's either a detergent or a chaotropic agent in these specimen collection tubes. Those agents are performing the first step that's necessary to perform a molecular test, and that is lysis of the target organism. So you can see like a detergent, for example, in this slide, would bind to the membrane in the collection vial, open up the membrane in many locations, and then therefore rupture it and then destroy the target cell, spilling out the DNA or RNA, which we really need to detect. But keep now in mind, why do I press this issue about viability is because if you did want to do, let's say, phenotypic drug susceptibility testing, when I say phenotypic, I mean, let's say, old-fashioned drug susceptibility testing. Does it grow or does it not grow in the presence or absence of a drug? That's not possible once you've collected these specimens for NAT testing. This is critical because I told you earlier that molecular tests are really powerful because we can describe them through molecular means, like look at drug resistance. But now I'm telling you that we can't do drug susceptibility testing because we're using a NAT. So it sounds counterintuitive. But in fact, what I'm really saying is that because when we run a NAT test, we're actually killing the organism, we need to look at drug susceptibility now through a nucleic acid-based lens. That is, we need to read the DNA or RNA to make our drug susceptibility predictions because we don't have a viable organism. So in terms of, as I said, the ability to run things quickly and to multiplex them, nucleic acid amplification tests allow hundreds to perhaps even thousands of specimens to be processed a day in the laboratory. And another note is that while we think of these as vaginal or urethral or urine type specimens, 3 companies have now generated FDA approval for rectal and pharyngeal swabs. And I will name them here. So on the Abbott M2000, the 70 gene expert in the Hologic Panther, you can actually get rectal or pharyngeal testing. So if you're in a community or in a jurisdiction where you might say have a large MSM, men who have sex with men population, these would be of critical importance. But in any population, they would be important. I said to you there was a waived test. So most tests are moderate or high complexity, according to FDA and CLIA, but there is now a waived molecular test on the market here. It's a little machine. I think it runs 1 or 2 specimens at a time. And in 30 minutes on either male urine or a female vaginal swab on this machine, which is called a Binks, you can test either asymptomatic or symptomatic people. So if you're in a clinic and you think, wow, I'm never going to see this patient again, and you really want to get that result and decide whether to treat or not, you can benefit from a waived test sort of like this. Gonorrhea, what we're most concerned about is when we talk about describing positive gonorrhea cases is drug resistance. For gonorrhea, everything that we've thrown at it, it has developed resistance, from sulfa drugs to penicillins. Penicillins were great because we have a great therapeutic index. When you get resistance to a little penicillin, you can give more penicillin. But eventually the organism out in the world developed enough resistance that penicillins were ruled out. We went to tetracyclines and we lost those in about 10 years. Went to fluoroquinolones here, ciprofloxacin being the drug of choice, and lost those, depending on where you lived, right around the year 2000 or maybe a few years later. And then we went to 3rd generation cephalosporins. So when we talk about cephalosporin drugs, which is where we're at now for treating gonorrhea, we have both oral and injectable cephalosporins. If we grind down in, we then in 2012 started to see a significant amount of resistance to oral cephalosporins in the world and a little bit in the United States. So the recommendations to treat gonorrhea were switched. And in 2015, we were now at the place where gonorrhea needed to be treated by an injectable cephalosporin, and that is ceftriaxone in combination with azithromycin. So think about that. Gonorrhea in 2015, the firm testing treatment recommendation was 2 drugs. And you could say, wow, that's an oral azithro and an injectable cephalosporin. That had a huge impact on disease control because typically public health jurisdictions do what's called partner-directed therapy, which is to say when they find a case, they'll give you pills to give to your sex partners. Well, that's you can't do when you're using ceftriaxone because it's injectable. So when we went to this regime, we really lost the ability to do partner-directed therapy. Now, what was really good news in the world of public health was that ceftriaxone and azithro was very, very successful for many years. For about 5 years, we saw no development of resistance to this regime, and we saw no further development of resistance to cephalosporins. So the 2020 STD treatment guidelines from CDC went in reverse and said, let's take azithro out of that, and we'll just keep treating gonorrhea with 500 milligrams of injected ceftriaxone. And these are still the current guidelines. So now we're back to 1 drug because the double drug was so successful. Why did we switch back, though? Why turn the clock back just to 1 drug? It's easier to do good antimicrobial stewardship with 1 drug. Number 2, microbiome concerns. We didn't want our microbiomes in these patients to be developing resistance or have too much exposure to azithro when it wasn't necessary. We generated a lot more pharmacodynamic data, which allowed us to see that this 1 drug would probably be efficacious. And also we started to see a tiny bit of azithromycin MIC creep, which is to say we saw the MICs in gonorrhea starting to creep up. We don't want to lose azithromycin because we're really running out of drugs here. So removing it would remove the pressure for that MIC to creep up. So now we're leaning strictly on injectable ceftriaxone. And note that if there's an allergy to a cephalosporin, gentamicin plus azithromycin is the treatment recommendation still. Now, how do we know about resistance in gonorrhea? I told you several slides ago that when we test for gonorrhea all over the world, we're using NAT tests about 99.9% of the time. And when we use them, we can't do culture. So how do we know about drug resistance in gonorrhea? How do we know all of this? Well, the fact is CDC was, and I guess until a couple of weeks ago, performing routine surveillance of drug resistance in gonorrhea. And that meant that they were looking at 28 sites across the United States where they did retain the ability to do culture-based culture-based detection of gonorrhea. If gonorrhea was found, they asked these 28, in each of these 28 sites, the first 30 cases of gonorrhea that would be found at certain clinics would be cultured and then sent to CDC labs that were designated as drug susceptibility testing labs. And then they would generate reports like this. You can see 1, 2, 3, 4, 5, 6 drugs across here. So they would do drug susceptibility testing to an array of drug types, generate MICs, and then send these tables back to the public health jurisdictions that captured the cultures. So this was a way of looking at MICs through the culture lens. And it was really the only drug susceptibility testing that's been going on for gonorrhea over the last several decades. But it does give us a look into what's circulating to some degree. But you can see if we're only looking at a handful of isolates from 28 jurisdictions, you're very likely not getting a terribly comprehensive view, but it's something instead of nothing. And just a quick note that now that we are using molecular tests, and you need to be able to assess treatment failures. And so the way a treatment failure is defined right now, according to CDC recommendations, is if medication is provided at, let's say, time 0, a failure would be defined on a molecular test as NAT positive greater than 7 days. So if you come in for a test of cure after you've been treated for gonorrhea and you're still positive on a NAT test more than 7 days later, it's considered a treatment failure. For throat infections, or pharyngeal as we may call them, it might be out 7 to 14 days. It might be as far as 14 days or 2 weeks later, they'll come and test. The alert values that we're really looking for in GISP, which is the gonococcal isolate surveillance project that we just described, that CDC was doing to look at drug resistance phenotypically in gonorrhea. We are looking very specifically for these MICs to these 4 drugs. So 2 of these are oral cephalosporins, cefixime and cefpodoxime. Ceftriaxone's an injectable, and azithromycin, of course, is an oral drug. But now we're leaning right on ceftriaxone, which is the injectable cephalosporin. And in GISP, we were looking for MICs of 0.125 or higher. But remember this slide I showed you earlier. So again, I'm telling you that 99% or more of virtually all diagnostic gonorrhea testing is being done using a NAT test. So we really can't do culture. Is there anything that we can do? So what really can we do if we don't have culture available to us? So we want to know drug susceptibility in a gonorrhea case. Now, all we have is a tube full of dead cells. Well, all of drug resistance in gonorrhea and in all organisms is genomic. That is, it's a genetic trait, which is to say it's written into the code of the DNA. And so because PCR can look at sequences that are very specific in DNA, we can use PCR to some degree to look for mutations that are associated with resistance. A very, very good example in gonorrhea, and the one we're going to concentrate on, is fluoroquinolone resistance or susceptibility. So the next few slides will talk about that. From the molecular testing perspective, there are no FDA-cleared molecular tests to ascertain resistance. So while we're going to talk about this, keep in mind these aren't FDA-cleared. In terms of what drugs we can make good predictions for from the molecular perspective, ciprofloxacin, that is a fluoroquinolone, is really the best choice. And I'll get into this in a minute why. We have mutations in the gyrase A gene mutation in Neisseria gonorrhea that are very, very consistently found in resisting cases. This serine 91 to a phenylalanine. It's a very, very consistent finding. So it's a very reliable mutation to use to make predictions. There's a couple of bodies of strong evidence for molecular testing of ciprofloxacin susceptibility. There's actually several papers. 2 here there is a test off the shelf that's not FDA cleared called the SpeedX. And there's a report here by Ebayan that looks at that. And then there's several LDTs that have been published that look at the serine 91 to phenylalanine mutation and have found very, very high consistency of that mutation with fluoroquinolone susceptibility in gonorrhea. If you're talking about tetracycline or penicillins or cephalosporins or azithromycin, we really don't have reliable data to show molecular resistance testing for these other drug classes. Tetracycline's close, but for these other drugs, it's much more complicated. So we're really focusing on using molecular testing to ascertain drug susceptibility for fluoroquinolones. You might say, well, gee, we're using ceftriaxone. That's a cephalosporin. Can't we just go ahead and really home in on cephalosporins? And the problem is that the mutations that are associated with cephalosporins are quite varied. There's a vast number of alleles in the PEN-A gene that can lead to resistance to cephalosporins, but there's so many and we don't even know them all yet. They more and more keep popping up. So there's seems to be an ongoing evolution here that we haven't really tracked to in its entirety what all the mutations are. So we can't really then very well make good molecular tests if we really don't know what we're looking for. The spectrum of alleles is just too great. So right now, again, we're really just focusing on using PCR to ascertain susceptibility to fluoroquinolones. And so this serine 91 mutation changes the shape of the binding site of ciprofloxacin in gyrase A, so that ciprofloxacin simply can't inhibit gyrase A function anymore. So you get resistance just simply by that 1 point mutation. You get a very, very large amount of resistance. So this is very easy to detect with a PCR that might use a hybridization probe. So for those of you that aren't familiar with hybridization probes, one way of detecting your PCR products in real-time PCR is to use fluorescence resonance energy transfer. So your probe detects your PCR amplicon by sitting down on it and then generating fluorescence when both probes are sitting next to each other. If one of those probes is sitting on a mutation, like let's say the serine 91 mutation that we're talking about, it destabilizes the probe. And so it's easier to melt those probes off. So you can, at the end of the PCR reaction, ask, at what temperature can I really easily blow those probes off of their target? And when the mutation is present, there's a destabilization, which means you can see the probes get knocked off their target at a much lower temperature. This is what an assay we ran in San Francisco to look for the serine mutation in positive gonorrheas. And you can see it's very nice. You can see not only the positive ones, the resistant cases, you can also see the susceptible cases because the probe binds and it requires a much higher temperature to knock them off than for the resistant cases. This is a clinical trial which I commend to your attention, by Jeff Klausner. It was done a couple of years ago. And this is showing great promise for this PCR in terms of taking positive cases, running the PCR, and deciding, can we use an old drug like a fluoroquinolone to treat these cases? And it was extremely effective in this trial here that you can see in CID. Moving on to Mycoplasma genitalium, we have quite a lot of resistance in this organism as well. The resistance is largely to azithromycin, which is the primary treatment of choice. The prevalence of resistance, depending on where you are, can go anywhere from 44 to 90%. So this organism is really trucking along with resistance to azithro. There is resistance also in Mycoplasma genitalium to fluoroquinolones, and the resistance is anywhere from 0 to 15%. It's interesting, Mycoplasma genitalium, it doesn't have a cell wall. So this is really an ancient organism. So you can't even use penicillins or cephalosporins or carbapenems to treat Mycoplasma genitalium. So to lose just azithro and fluoroquinolones is a big deal. And so it really starts to limit your treatment. So anything we can do to do better stewardship or to detect resistance and to treat this organism more tactically, we'll take advantage of it. Just to keep in mind that Mycoplasma genitalium can cause cervicitis, pelvic inflammatory disease that can result in female infertility, or in men it can be urethritis or proctocolitis. So there is really a range of harm that this organism can do. And so to see treatment resistance or drug resistance in it is quite a thing that we need to pay quite a lot of attention to. There are assays in the literature and in the non-FDA cleared universe or research universe that can detect the mutations associated with resistance in Mycoplasma genitalium. In the United States, none of them are FDA cleared. But just for everything I just said about gonorrhea, where if we could, at the time of diagnosis, use a molecular test to also ascertain susceptibility to azithro and fluoroquinolones, it would allow us to treat Mycoplasma genitalium far more tactically than we're doing so now. And not having to use culture to do it would mean we could treat tactically and in real time. So I thought it might be useful for the audience to know what actually the CDC recommendations are for Mycoplasma genitalium. And they're saying, if somehow you are able to determine susceptibility and it is macrolide sensitive, which is becoming more and more rare these days, then here's the treatment recommendations. It would be doxycycline followed by azithro. If you're dealing with a macrolide resistant case or an azithro resistant case, doxycycline and moxifloxacin would be your choice. So if you were able to use a molecular test to find those mutations, we have 2 opportunities to treat depending on what the outcome of that would be. So moving on to our last organism, Trichomonas vaginalis, treatment and resistance. There are firm treatment recommendations for Trichomonas vaginalis. They differ a little bit between men and women. Women can take a lower dose 2 times a day for 7 days. Men take one dose, one very large dose orally in a singular format. There is an alternate regimen for either gender, and that's tinidazole, 2 grams orally in a single dose. This is a eukaryotic organism, by the way. Of all the organisms we've talked about today, this one's actually more like us. It's got, it's got a far more complicated genome, by the way, but it's still detectable by molecular means, as we said earlier. And now also its resistance mutations are being characterized. We do see resistance to metronidazole, in 4 to 10% of cases of vaginal trichomoniasis. So keep that in mind, that there is a reasonable amount of resistance to metro in Trichomonas vaginalis. For tinidazole, the resistance is less well studied, but in one study that was pretty good out there with a lot of specimens, 1% of infections were also resistant to tinny, which means that we're probably going to start facing a more and more uphill battle as time goes by with Trichomonas vaginalis. There aren't, again, any cleared assays that allow us to find resistant TV through molecular means, but the literature and PubMed, if you go through and scan that, you'll find LDTs, laboratory developed tests that aren't obviously cleared, that would allow you to find the mutations associated with resistance. And so our conclusions then, nucleic acid amplification tests are extremely sensitive and have a lot of advantages for detecting STD organisms. They keep in mind, however, that when we do NATs, we're generating non-viable specimens, and any drug susceptibility testing that we do would be limited to those for which we have molecular tests. Resistance is an issue for all of the organisms we talked about today, except chlamydia. In chlamydia, the main issue is strain typing to see if there's an LGV strain, possibly, which requires very different treatment. So again, assays are needed. In all of these cases, if we had molecular assays that were cleared, we could treat very tactically so that when we were detecting these organisms, we could also simultaneously find out if the mutations were present, so we could treat right there and then. And it might be the only opportunity we ever get to determine drug susceptibility because, again, as I said a few times, these organisms aren't alive when we do NAT testing. So we really do need to develop molecular-based tests to take advantage of this tactical opportunity to treat. And I'm grateful for your attention, and I thank you for the opportunity to talk to you about this today.
Thank you, Dr. Pandori. I will now pass this over to our second speaker, Dr. Takal.
Hello, everyone. My name is Bijay Dhakal. I'm the Director of Molecular Laboratory at Sonic Reference Laboratory in Austin, Texas. Today, I will be reviewing the landscape of STI testing and antimicrobial resistant testing, specifically focusing on Mycoplasma genitalium. Globally, sexually transmitted infection continue to pose a significant public health burden. Summarized in the slide are the top 10 sexually transmitted infections encountered in the US. They are ranked according to the prevalence and/or incident in the US. Worldwide, approximately 1.8 billion, and in the US, about 72 million people have infections categorized as sexually transmitted infections. Despite very sensitive diagnostic tools and effective treatment options, some of the curable STI, for example, trichomoniasis, chlamydial infection, syphilis, Mycoplasma genitalium infections, and gonorrhea remains widespread with increasing incidence according to the CDC's 2023 surveillance report and WHO's most recent estimates. To prevent the transmission of STI, various public health agencies have put forward testing recommendations summarized in the slide for Chlamydia trachomatis, Neisseria gonorrhoeae, and Trichomonas vaginalis, which I will be referring as CT, NG, TB, or TRIC in my subsequent slides during the talk. While the slide is not exhaustive, the summary from the guidelines provide a quick overview of targeted screening based on risk, population, and infections. For example, asymptomatic transmission of STI is a significant problem globally. Thus, all guidelines recommend asymptomatic screening of high-risk population. I would like you to focus on the top two rows of the table that is projected in the slide. As you can see there, asymptomatic screening of women less than 25 years of age and asymptomatic screening of MSM are performed every year, unless they are of high risk and they are screened frequently. The slide I know is very busy, but my intentions are not to cover the guideline, but to give an example that public health agencies' efforts to curb the transmission of the three most curable STI. For detailed information, I encourage you to review CDC or other public health agencies' STI screening recommendations. Testing plays a central role in diagnosis and prevention of transmission if the test information is utilized appropriately. Nucleic acid amplification tests, or NATs in short, are now the gold standard for screening and diagnosing CT, NG, and TB. These tests offer exceptional sensitivity and specificity, making them the preferred method in both clinical diagnostic as well as screening setting. While most of the NAT testing is performed in a traditional clinical laboratory, testing options closer to the patient, such as point-of-care setting or even at home, would likely provide increased accessibility, allowing early detection of pathogens and prevention of transmission, especially among high-risk but under-screened populations. STI infections are associated with stigma, and there could be a barrier in seeking medical attention. Providing at-home testing may just break that barrier. In the subsequent slides, I'll review how FDA is helping to bring the STI testing closer to the patients. The majority of molecular assays performed in clinical laboratories are frequently designed as combo tests to simultaneously detect pathogens that cause STI and can present with very similar symptoms. Commercial assay from manufacturer listed in teal color text in the slide. Manufacturer combo assay for simultaneous detection of CT, NG, and TB. Most of these tests accept a wide range of sample types from urogenital sources, including urine and swabs from vaginal as well as urethral. Some of the tests are now offering testing on extragenital sites such as pharynx and rectum. Clinician collected specimens and self-collected vaginal or rectal swab in some instances are also acceptable for testing by these molecular assays. I already showed you this slide, but I want to reiterate the fact that the tests used in the clinical laboratory have excellent test sensitivity and specificity, generally exceeding 96 to 98%, making them highly reliable tests for detection of CT, NG, and TB. Because of public health concern and the rise in number of STI cases year over year, providing an easy access for testing might help early detection of infections, prevent transmissions, and ultimately bring down the number of active cases globally. Testing at point-of-care setting may achieve that goal. In 2021, FDA approved the very first point-of-care testing for CT for molecular assays. This test offers equivalent sensitivity and specificity to that of a traditional NAT performed at a clinical laboratory. Testing at point of care is now available for CT and NG on female vaginal swabs as well as male urine. The test provides results in 30 minutes, and these are CLIA wave tests that can be performed in different doctor's office, such as physician's offices, community-based clinics, urgent care setting, outpatient healthcare facilities, or other patient care settings. FDA took a step further in providing broader accessibility of molecular testing closer to the patients. In 2023, the FDA approved a direct-to-consumer test that can be purchased without a prescription, allowing individuals to collect samples privately at home and send the specimen to designated laboratory for testing. Since the testing portion of the approval is done in the clinical laboratory, the test provides the same assay sensitivity and specificity as routine clinical molecular tests performed at clinical laboratories. In the US, a significant year-over-year increase in syphilis cases has been reported since the start of COVID pandemic in 2020, posing a significant public health concern. FDA approved the first over-the-counter syphilis antibody test that can be used at home for testing. The test requires a finger prick for testing, and the results can be obtained within 15 minutes. This test shows high concordance with FDA-cleared tests, offering new potential for accessible testing, especially at risk population and in population with poor healthcare access. At the end of last month, FDA approved molecular-based at-home test that can detect 3 important causes of STI: CT, NG, and TB. The test sensitivity of this at-home test is equivalent to that of clinical laboratory test. Testing can be performed on vaginal swab at the moment. However, the manufacturer will likely extend the testing to male urine samples in coming days. The test provides test results in about 30 minutes. I have showed examples that how FDA is helping patients to get tested closer to the disease and at home. I've already showed you a slide, but I would like to highlight another important pathogen that I will be discussing through the rest of my talk. Mycoplasma genitalium, or Mgen, is another common curable bacterial cause of STI worldwide. Mgen is an emerging STI that causes urethritis, cervicitis, and pelvic inflammatory disease. In the US, more than 2 million cases, and worldwide, more than 200 million cases of Mgen infections are recorded every year. This is a summary slide for recommendations for Mgen testing from 3 public health agencies: CDC in the US, UK, and Europe guideline. Unlike CT, NG, and TB, there is no specific screening recommendation for Mgen in asymptomatic individual. Testing is only recommended in an individual with clinical presentation of STI, and also the sex partner of individual who tested positive for the bacteria. The slide is not supposed to be a comprehensive list of recommendations, rather a general brief overview of available recommendations. For detailed information, I encourage you to review CDC or other public health agencies' STI screening recommendation. The recommendations are living documents, and they get updated while new information are available. The guideline from UK is in the process of revision, and an updated draft guidelines is available for commenting and critique. For Mgen testing, antigen test, microscopy, serological tests have been developed and described in literature. However, they are not recommended for routine diagnostic uses due to lack of sensitivity and specificity. These assays are not commercially available, and the clinical utility of these tests are not well established. Thus, these tests are largely used for research efforts only. Mgen was first isolated in 1980 from the urethral specimen of a male patient with non-gonococcal urethritis. However, culture for Mgen diagnosis is rarely performed in a clinical setting these days. The bacteria grow very slowly, thus extending turnaround time to 6 weeks or even longer. In addition, it requires a specialty lab and special media to perform the testing. Its such culture is also limited to research application, just like other testing modalities that I described in my earlier slide. PCR remains the most practical and sensitive method for detecting Mgen in patient specimens. Since its first introduction for Mgen detection in 1990, a number of LDTs are developed for detection of Mgen. These LDT utilize several genes in Mgen. Some of those are listed in the slide, including MGPA, 16S rRNA, GAP, and DNA gyrase subunit A. Since 2019, a number of commercial FDA-approved assays have been available in the US. These tests are available as a standalone test to detect Mgen or as a combo test for simultaneous detection of multiple pathogens, including CT, NG, TRIC, etc. Testing is available on a wide range of specimen types from urogenital sources. Most tests are approved for first void urine and swab specimens from urethral, vaginal, endocervical, or penis. Clinical collected specimens and self-collected vaginal swabs are approved for testing on these tests. Similar to other FDA-approved tests for STI testing that I described during my talk today, the FDA-approved tests for Mgen detection have excellent clinical sensitivity and specificity. However, you may notice some older versions of the test in a particular sample type have slightly lower sensitivity and specificity, which will be corrected in coming days or are already corrected. Again, I would like to draw your attention particularly to the resistant testing section of Mgen testing guideline that I showed you earlier. All available guidelines recommend testing for drug resistance, specifically for macrolide resistance on individuals who have tested positive for Mgen. Because of the rising drug resistance, treatment decisions for Mgen infection now depend on the availability of macrolide resistance testing. Specifically, the use of moxifloxacin as a follow-up regimen to doxycycline depends on whether resistant testing can be performed on bacteria. As you can see on the slide, the testing recommendation depends on whether the testing is available or not. On the bottom of the slide, you can see when the testing is not available, doxycycline followed by moxifloxacin is the standard regimen. However, if the resistant testing is available and the bacteria is resistant, doxycycline followed by azithromycin is the standard regimen. If the bacteria is resistant, then doxycycline followed by moxifloxacin is the standard regimen for treatment. This slide summarizes the worldwide prevalence of macrolide resistant Mgen. Macrolide resistance in Mgen has been detected in many countries, particularly in the US, Canada, Western European countries, Russia, China, Japan, Australia, New Zealand, and South Africa. The drug resistance rate varies widely, as low as 1.7% in South Africa to almost absolute in Greenland. I would like to caution that the number of studies and the number of sample included in each study varies significantly from one country to other country. Thus, the number may be under or overrepresented uh, in the shown slide. There are a lot of countries where we do not know the prevalence of macrolide resistance in M. genitalium. Macrolide resistance rate in the US varies significantly among different populations. Very high rate of macrolide resistance has been reported in MSM and SIB positive population. Very low level are detected in heterosexual men and women. Macrolide resistance in M. genitalium is driven by mutations in the 23S rRNA gene, specifically within the peptidyl transferase loop of domain 5. Common mutations that are associated with resistance are listed on the right side of the slide. Specifically, A2058G and A2059G are the most common mutations detected and are associated with high resistance to azithromycin. Other mutations such as A2058C or T, A2059C or T are less frequently encountered. A third group of mutation, A206-G2T, is rarely encountered. All of these mutations cause high-level resistance to azithromycin treatment. There are no FDA-approved assays for resistant testing in Mgen. A few commercially available RUO assays are summarized in the slide here, including an assay from today's webinar sponsor, Applied Biocode. These RUO assays can be utilized to develop laboratory-developed tests and offer it for macrolide resistance testing. Most of these assays can detect the common mutation in the peptidyl transferase loop that I alluded in my earlier slide. Resistance to fluoroquinolone, although less common, is also on the rise. Resistance to fluoroquinolone is very similar to that of resistance to macrolide. Fluoroquinolone-resistant M. genitalium have been detected in the same countries where macrolide resistance has been detected. As you can see on the slide, fluoroquinolone-resistant M. genitalium have been detected in the US, Canada, Western European countries, Russia, China, Japan, Australia, New Zealand, and South Africa. The prevalence of fluoroquinolone-resistant M. genitalium also varies greatly from 0.4% in South Africa to 90% in China. The sample size in this study and the number of studies in this country could influence the prevalence rate. The distribution of population where fluoroquinolone resistance is detected is also very similar to that of macrolide resistant populations. Very high rate of resistance has been detected in MSN population as well as in SIB positive population. Low level of fluoroquinolone resistance has been detected in heterosexual men and women. The most alarming trend is the detection of dual resistance to both macrolide and fluoroquinolone in the US. Fluoroquinolone resistance is mainly associated with point mutation in the PARC gene, specifically S83I, which is commonly linked to moxifloxacin treatment failures. The PARC gene encodes a subunit of topoisomerase 4, a target for fluoroquinolone. Although rare, mutation in DNA gyrase subunit A can also contribute to fluoroquinolone resistance. Alone, gyrase A mutations are not always predictive of clinical resistance, but they enhance resistance when combined with PARC mutation. Thus, dual mutation in gyrase A and PARC have been associated with high-level resistance and moxifloxacin treatment failures. Apart from the S83I mutation that I mentioned in the previous slide, other mutation in PARC gene D87N, and D87Y can cause increased MIC in vitro and treatment failure, specific treatment failure in patients. Commonly detected DNA gyrase A mutations are listed in the table to the right side of the slide. Mutation in gyrase A codon 95 is the most frequently seen mutation in resistant strain. Other codons include 93 and 83 of the gyrase A gene. Again, there are no FDA-approved assays for resistant testing in Mgen. LDT can be developed using sequencing-based assays or by using mutation-targeted real-time PCR assays. A few commercially available RUO assays are listed in the bottom of the slide, including an assay from Applied Biocode. These RUO assays can be utilized to develop lab-developed tests and offer it for fluoroquinolone resistance testing. In the next few slides, I would like to draw your attention to CDC's report on antimicrobial resistant threat that was published in 2019. CDC listed at least 18 different bacteria or group of bacteria in 4 broader categories based on the threat they posed. These are urgent threat, serious threat, concerning threats, and watch list. 2 of the important causes of STI are also included in the list. Drug-resistant Mgen is under the watch list, whereas drug-resistant Neisseria gonorrhea is under the urgent threat. I know this is a busy slide with a lot of information, but you could appreciate the impact of drug-resistant Neisseria gonorrhea causing significant financial and public health burden. CDC estimates more than 1 million cases yearly, and of those, more than 550,000 cases of drug-resistant Neisseria gonorrhea infection every year. The financial cost of managing these infections is more than 133 million. I encourage you to review CDC's antibiotic resistant threat report published in 2029 for further information. This is the final slide of my presentation, and I would like to share my final thought on drug-resistant testing for Mgen. Since drug-resistant testing for Mgen is not available widely in the US, one area of improvement the clinical laboratory community and test manufacturer could contribute is by making testing widely available and accessible. We all know that testing provides an important tool to identify drug-resistant Mgen and manage it appropriately. Without this, we will not be able to manage the threat posed by drug-resistant bacteria. After all, we do not have a huge list of antimicrobial agents to treat drug-resistant Mgen or any other pathogens. With this, I would like to thank you for your attention today and would be happy to take any questions you may have. Thank you again.
Thank you, Dr. DeCall, and we'll now pass this over to Joe Davis to give his presentation.
Thank you. And hello, everyone. We're going to transition to the next portion of the presentation, navigating the STI and AMR trends. For this, we're going to be reviewing some preliminary overview and findings from the ABC 101 study, a prospective sample collection study for the assessment of the Applied Biocodes STI resistance panel and RUO panel. It's a comparative assay from Abbott, the Alinity M, their STI panel. I'm Joe Davis from University Clinical Health and Department of Pathology. Starting over, so we're going to take a closer look at the ABC 101 study, which compares the Biocode STI Plus resistance panel and RUO panel to the Abbott Alinity M STI assay. The study's objective is to collect prospective samples to evaluate Biocode's performance in detecting chlamydia trachomatis, Neisseria gonorrhea, Trichomonas vaginalis, and Mycoplasma genitalium, plus the antimicrobial resistance markers, specifically fluoroquinolone and macrolide SNPs in gonorrhea Mycoplasma positive samples. The Alinity M assay serves as our competitor because it's detecting all the same 4 targets in a single reaction, but without the AMR detection. And this serves as a good benchmark just due to its FDA cleared status and high validation performance compared to some of the other first generation NAT assays in the market, such as Hologic and Roche, and offers comparison for all 4 targets in a single test kit. This is an IRB approved study through Advara, requiring informed consent from all the participants. It's in 2 phases, as 2-phase design. We're going to be focusing on the first phase today and reviewing our data. The part 1 which is a collection of 20 positive urine samples for each pathogen and 5 AMR positive samples for gonorrhea and mycoplasma. And then in the future, part 2 really focusing on the collection of vaginal, rectal, and oropharyngeal swabs with those same targets. But for phase 1, we're recruiting males at birth, both symptomatic and asymptomatic, who are eligible for the HIV PrEP or suspected of having STI infection, aiming for 80 positives total across all targets. The population size is dependent on prevalence of each target, obviously, especially for hard to find positives like gonorrhea, as we saw earlier. But the performance of the study, will be measured by calculating the positive % agreements and the negative % agreements for all 4 targets against the Alinity M, with AMR results being validated through third-party sequencing using Biocode Cyber PCR assays, which is going to act as a tiebreaker for discordant results as well. The study will give us a clear picture of the research, for those discordant results. So, in slide 2, moving on to slide 2 here. All right. So we have 2 testing sites for the study. One is the Applied Biocode in Santa Fe Springs, California, which is handling the STI plus resistance panel, and then University of Clinical Health located in Memphis, Tennessee, where we're running the Abbott Alinity M STI assay. UCH has verified the Alinity M assay for clinical use and is CAP accredited, CLIA certified laboratory. We work in partnership with the University of Tennessee Health Science Center, as well as with multiple medical systems here in the Memphis area. So we're quite familiar, unfortunately, probably with STIs with our patient population. But the samples have been collected at 3 for this study have been collected at 3 sites, Access Research Group sites in New Mexico, Utah, and Texas. And the studies try to streamline sample collection with specific inclusion/exclusion criteria in this first phase, really including that participants, it said it must be male at birth, 18 years or older, willing to self-collect urine, and either asymptomatic or symptomatic for one of the 4 targets, in which examples that would symptoms be like urethritis or abnormal discharge. Anyone that was, had urinate for exclusions, anyone of those, potential participants that urinate less than an hour beforehand, were excluded, and that's just all just to ensure reliability of sample quality. And then, as you can see, kind of the flow in the map here, those samples were shipped weekly to a UCH and Applied Biocode from those collection sites, when the results were shared back with the collection sites in the Access Research Group here. So let's do a quick overview of the workflow for this study. So after self-collection, each urine sample is split. So 3 mLs of urine are transferred into the Abbott's collection device, the multimedia, multi-collection media, proprietary for the Abbott Alinity M. And the remainder of the sample, 5 milliliters of Strec preservative media are added to that sample, and then a portion of that's transferred into a yellow cap urine collection tube. So those samples are transferred to their respective sites by overnight shipping. And then the study so we're directly comparing the 2 assays from the same sample simultaneously in 2 different locations. The results from both sites are shared back with Applied Biocode and the Access collection sites. So we're trying, any scenarios where we have agreement, we're matching results of ID between chlamydia, gonorrhea, trichomonas, and mycoplasma. Those results are logged back in the database, but any discordant samples are resolved via Sanger sequencing by a third party. So that's our tiebreaker. And then, as well as this, in addition, for any gonorrhea or mycoplasma positive samples, the Biocode STI plus resistance panel is picking up, obviously for any mutations within the antimicrobial resistance for those S&Ps. Those positive are being confirmed by the same Sanger sequencing assay as well. So before we move into looking at reviewing some of the data from the study, I just want to give a quick overview, a side-by-side comparison of the two platforms. Starting with the Alinity M, we run here at UCH. We are using the platform clinically, as I said before, with our patient population. It's a fully integrated and continuous random access PCR analyzer. So taking it all the way from sample in, answer out, that can delivering the first results typically within about 115 minutes for the STI assay. So very high throughput and quick result timing. It does include 2 levels of internal control within the reaction, an endogenous human cellular control, as well as an exogenous armored RNA that's spiked into the sample at the time of extraction. Really, I mean, for this instrument, it's best suited for like high volume laboratories, running multiple assays. They have several others beyond just STI, both for like respiratory, viral load monitoring. But it does show high agreement with a lot of the other FDA approved assays that are on the market, such as Hologic Panther and the Roche system as well. Now, the Biocode STI plus resistance panel. This is a research use only assay at this time, but it does involve some offboard extraction and PCR setup. It has, for some of the other assays, Applied Biocode has validated extraction steps on systems such as the Roche MagnaPure and the Thermo Kingfisher for some of the other test offerings like GPP and RPP. So there's flexibility for labs based on just throughput needs, some being higher, whether it be low or high volume needs. But the PCR and detection happen on board the Biocode MDX3000, and obviously the unique strength for this assay is it's detecting for the macrolide and fluoroquinolone resistant SNPs in the gonorrhea and Mycoplasma genitalium positive samples that we're going to see. So it's I think a real benefit for monitoring trends for antimicrobial resistance, as well as potential treatments and sites in the future. ABC platform, it processes around 144 samples plus controls in an 8-hour shift. It's using a 96-well plate system, so it's roughly 2 plates, per the 8 hours, and then with the DNA internal control added during extraction. So how do these 2 assays, how the performance characteristics of the 2 assays compare? So we're going to take a look at the results overview here. Across the 3 collection sites, we've up to this April 14th or April 15th of 2025, we have tested 452 samples in total, 137 from the Texas site, 103 from New Mexico, and then 212 from the Utah site. The Biocode MDX3000 system has identified 34 positives across all 4 targets, while the Alinity M has identified 33. So we're looking at really like at the time of making this, at one point it was around 9%, but it's really been around 7 or 9% for the average positivity rate across all 4 targets. And you can see down at the bottom our comparison from our initial results and then our post-discordant. Before discordant resolution, the performance metrics showed some varied positive percent agreement across each target. For gonorrhea, it was at 50%. Chlamydia and trichomonas were both at 100%, and the Mycoplasma at 88%. And then the negative percent agreement was high across all, 99 to 100%, mostly. But after resolving discrepancies with Sanger sequencing, we see the results improve significantly and generally in favor of the Biocode assay relative in trichomonas and Mycoplasma. You see gonorrhea's percent agreement jumped to 100%, Mycoplasma rose to 96, and then both chlamydia and trichomonas stayed at 100, with the negative percent agreements jumping to 100% across all targets. Showing, I think, for both assays, very highly accurate, and then with the sequencing tiebreaker, some of these results, especially within trichomonas and Mycoplasma, lean more toward the Biocode assay, just in direct ID for these organisms. And then really looking at the Biocode's offering for the antimicrobial resistance detection. we're looking at this, our gonorrhea positive population is still too small to really derive any insights from. But of the 23 mycoplasma positive samples, on which only a portion have undergone sequencing at this point, there's been around a 50% prevalence of one or more AMR S&P mutations detected. So out of the 8 samples, 6 have shown a perfect match when compared to sequencing. But there were some misses, a miss for PARC S883I in sample 1063 up at the top chart there, and a partial miss in sample 2032, where additional SNP was detected upon sequencing. Really looking at these samples, and you see some details to the right. Just upon further investigation, there was visual evidence, when looking at the graphs, for a potential mixed population with one of the samples for 1063, where it's called a series of AGT, but there is some evidence there of another population of ATT being in that sample as well, potentially leading to the reasoning for that miss. And then also looking at the other sample, there's just another possibility being just a low level of infection below the limit of detection for the assay as another potential explanation for the partial miss there for 2032 as well. But overall, just from looking at this data, we can see that Biocode has achieved, has detected like 7 true positives out of this group with a positive percent agreement of 77.8%. And you see the breakdown for each of those target now. So far, it's performing well. It's very exciting to see some of this data come through, and there's possibility for detection for these antimicrobial resistance markers that we're seeing. So in review, just some observations, conclusions up to our preliminary data up to this point. Obviously, it's still ongoing. The Biocode STI plus resistance panel is showing higher equivalent sensitivity for the 4 targets compared to the Alinity M. We're specifically focusing on Trichomonas and Mycoplasma. We've seen about a 6% positivity rate within the study population for those 2 targets. And it's notable for the Biocode that's comparing very well, that around 50% of those Mycoplasma strains have also shown at least one AMR SNP, highlighting its potential value for antibiotic stewardship, and I think in high-risk populations or high-risk groups. So the Biocode's ability to detect fluoroquinolone and macrolide resistance in the gonorrhea and Mycoplasma positive patients, combined with a high sensitivity and the fast turnaround time scalability platform, I think provides makes it potentially a powerful tool for just better informed antibiotic decisions and trending. So, as we continue in the middle of phase 1 here, moving into phase 2, as we're looking ahead, we're excited to continue to add more positives and AMR data to this data set. And obviously with phase 2 bringing in swab collections to expand on the insights. So that concludes my portion of the presentation. So I thank you everyone for your time, and I'll hand it off.
Thank you all for your informative presentations. We will now start the live Q&A portion of the webinar. If you have a question you'd like to ask, please do so now. Just type your question into the Ask a Question box and click Submit. We'll answer as many of your questions as we have time for. Let's get started. Our first question says, it seems that there was a high AMR percentage of Mg samples tested compared to what has been seen in literature. Can you explain this? I believe that's for Joe.
Yeah, I'm happy to answer that, and thank you for the question. I think it goes back to you don't know what you don't know, and just as we see more as testing is expanded and capturing more of the prevalence of Mg in the populations, I think we're just recommending, seeing that despite that there being not, I think just because Mg is not being widely tested in individuals, we're not there. Like a lot of chances they're not getting proper treatment. So over time, the undetected Mg is being transferred from one person to another. Eventually, becoming resistant. So it's really going back to it's not a widely used clinically now. But as we're just kind of seeing as testing expands, we're seeing more and more prevalence of Mg in the population. I think going back to Dr. Dockel's presentation, I think some of the the data that he shared is that around 2 million or so Mg positives are detected annually, even just within the U.S. So I mean, this is I think an organism is out there, and it kind of is growing in prevalence. So
great, thank you. And I believe our next question is also for you, Joe. This question asks, what extraction system do you recommend for extracting DNA from urine samples, and how much volume?
Or how to get back off mute again. Yeah, great question. So I think it largely depends on the laboratory needs, capacity for as far as extraction. A lot of the FDA-approved platforms for STI testing have onboard extraction, but even the ones that don't, like Applied Biocode, there are options. For this study in particular, for ABC, for Applied Biocode, a lot of the feasibility testing has been done on the Roche MagnaPure 96 system. So that's one system definitely to use. But even before that, there was even outside the feasibility, just initial studies. There was some swab testing done on both the MagnaPure and then the Thermo Fisher Kingfisher extraction system. So those are two options that are used as off-board extraction. And I think just from my own perspective, I've seen the Kingfisher grow in its use in the laboratories over the last 5 years or so.
Thank you. All right, our next question, we're going to jump over to Dr. Pandori. This question asks, does a positive result on a NAAT looking for a DR mutation always mean that there is a resistance expected? And if not, why not?
That's a really good question. It gets right at the nature of what these tests look for. The NAAT tests are looking for mutations. So you could get a positive result on a NAT for an NAAT for a mutation. The mutation may be associated with drug resistance, or it might be what we call a silent mutation. A silent mutation is a mutation that doesn't change the amino acid that's coded in the protein. It could also be a conservative mutation that brings an amino acid into the protein that doesn't actually confer resistance. So you can have mutations that would trigger a NAT test, but wouldn't necessarily be causative of resistance. And we do see that in the TB world a little bit on occasion with the rifampin test. So the answer is, it's a good question, and the answer is, it doesn't absolutely mean that resistance is present, but it is a very, very high probability that there is. Thank you.
Thank you. And we have time for one more question here today, so we'll pass this question over to you, Dr. DeCall. This question asks, do we already know the limitations on the at-home health kit, or is this still in the developmental phase?
Thank you for the question, and it's a very important one, as the other questions there. Since the COVID pandemic, there is an interest on at-home testing, because as I alluded during my presentation, that at-home provides testing at your convenience, and you don't have to set up an appointment, go to the doctors, and do all that thing. So it would be very easier to get an answer for any condition that you have. Having said that, there is always limitation on test. Not every test are perfect. Some of the limitation of that test will be included in the package insert of that particular test. And one of the important thing is the test that I talked about, the one that was approved last month, is the VisBi one. It's a molecular test over the counter. You don't need a prescription to use that test at home. What FDA makes sure when they approve the over-the-counter test are that they are foolproof. In that way, they ask the manufacturers to test many scenarios that a user can screw up the test, for lack of a better term. And so they have kind of panned out all of the things that are associated with the test problems and determined that they are likely to be working as intended. That's why they approved that as over-the-counter test. And as I said, the limitation would be in the package insert if there are any. And I'm sure there are a lot more tests that are in development. People are interested in expanding this market and providing the testing closer to the patient. So we'll see more testing come as over-the-counter or at-home test from FDA, and those are going to be approved in coming days. Thank you again for the question and listening to our webinar today.
Thank you, Dr. DeGaulle. I want to thank you all for your time today and your important research. We would also like to thank LabRoots and our sponsor, Applied Biocode, for underwriting today's educational webcast. Before we go, I'd like to thank the audience for joining us today and for their interesting questions. Questions we did not have time for today and those submitted during the on-demand period will be addressed by the speakers via the contact information you provided at the time of registration. This webcast can be viewed on demand. LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. Until next time, take care, everyone. Goodbye.